Good morning, everyone. I am Dr. Laura Lacher, and welcome to today's Medical Grand Rounds. As usual, we'll get started with a few reminders and then get into introductions for today. Please be sure to join us next week for a very special Grand Rounds. We will be hearing from the Providence St. Vincent residents and medical students who will be presenting work that they have prepared for the Oregon American College of Physicians poster competition. So please be sure to join us next week. We, of course, are here live in Southern Auditorium at Providence St. Vincent. Grand Rounds is a collaboration between St. Vincent and Providence Portland Medical Centers. We are often here live on Tuesday mornings at 8 a.m., and sometimes our speaker is live at Providence Portland at noon, also on Tuesdays. You can always see where we will be meeting in the weekly invite for Grand Rounds, and you can earn CME credit by being here in the room, by watching live on Teams, or by watching a recording of the event, and that recording is available at the same link as the weekly Grand Rounds invite. I'll be monitoring the Q&A throughout today's talk, so for those of you out there online, please go ahead and post any comments or questions, and I will mostly save those for the end as time allows. And now to introduce today's speaker, Dr. Katie Drago, an expert in geriatric medicine. She earned her medical degree from the University of Arkansas before coming to do internal medicine residency and then a fellowship in geriatric medicine at Oregon Health and Science University. Dr. Drago developed and then directed the OHSU inpatient geriatrics program from 2000 until 2021 and served as Director of Quality for Inpatient Geriatrics from 2021 to 2025. Her academic interest has focused on systems improvement in the care of hospitalized older adults. She led an interprofessional team of experts in expanding OHSU's age-friendly health systems program. And Dr. Drago currently serves as a facility medical director with Marquis and expert faculty for the Institute for Healthcare Improvement, working nationally and internationally on age-friendly health systems. Dr. Drago, many thanks for joining us today to lend your expertise and your passion for teaching.
Good morning, everyone. Thank you so much for the opportunity to be here, both here with all of you at St. V's and here with all of you on Teams. Thank you for making the time to join us. And I appreciate the warm introduction. We are going to spend the next hour talking about sleep, and don't think it is lost on me that it is early in the morning and we're talking about sleep in a nice, warm, kind of dark room. Not lost on me. So I'm going to try and do my sort of Shecky the Clown routine to keep everyone awake and engaged wherever they might be. We're going to talk about some medications, some sleep testing like polysomnography and other things. Just know that I'm a geriatrician. There ain't a lot of money in geriatrics, and so I have no financial relationships or contacts with any companies, research that we're going to talk about, any of the treatments or investigations. I am truly just sort of a clinician who has learned over the years and in training about sleep and why it's so important. So we're going to, I should start by saying the bulk of this talk is going to be kind of on chronic sleep issues, physiologic changes in sleep, things that in the beginning might seem a bit more relevant to outpatient providers, PCPs, specialists doing outpatient care. There is, because I see scrubs in the audience here, there is some information at the end too about sleep in the hospital because it is a little different. Obviously, we see the same issues, but management and how we approach it is a little bit different. So I've thrown in at the end a brief section on sort of sleep considerations in the hospital. But here are the topics we're going to touch on. First is sleep physiology changes, which can really be summarized as older brains, not the same as younger brains. Dive into some of the common sleep disorders, specifically primary insomnia or chronic insomnia, obstructive sleep apnea, and then the sleep-based movement disorders, so restless legs and periodic limb movement disorder. I will reference REM sleep behavior disorder. You'll see that in here. That could be a whole talk in and of itself. And so we're not going to dive too deeply into that, but tell Laura and the team, they'll have me back. And then we'll talk about a diagnostic approach that is more sort of older adult friendly. particularly for those with multiple comorbidities that can affect sleep, and then unpack the toolbox that exists, whether we recognize it or not, of all the things that we can do for people that are struggling to sleep. All right. Normal sleep changes. Everybody looks awake, so we're doing okay. Older brains, not the same as younger brains. So, in general, and everybody's different, it's worth pointing out there are some older adults that sleep 10 hours a night and they are just fine. And then there are other older adults that only sleep 4 hours a night and they are just fine. So, there is a spectrum of what's normal. These are general trends that are physiologically expected from aging, independent of medical conditions or disease. And so the three big buckets that we see are changes to the circadian rhythm. So the internal clock actually shifts. And there's a term for this in sleep medicine. I apologize if there's any sleep docs on the call, but they call it advanced sleep phase syndrome, which sounds very medical, but it really is just a shifting kind of up into the evening of the normal sleep clock, meaning older adults will tend to want to go to bed earlier than maybe they did prior in life, kind of 7, 8 o'clock ish. And then wake up earlier in the morning. So that sleep phase of our 24-hour day kind of shifts. There are reasons for this. There's an age-related decline in melatonin production, which is, believe it or not, the reason we throw melatonin at everyone. And then there's hypothalamic changes in temperature regulation, which, believe it or not, for those who have slept hot or cold, I know you know this, temperature is actually a major factor in getting successful sleep. And so if your body can't regulate quite as well, it's going to have some issues. Older brains tend to spend less time in REM sleep and deep sleep. That's the restorative part of our sleep. That's where we get cellular regeneration and repair. That's where we do our dreaming. That's also where we do the vast majority of consolidating of information, the kind of filing and organizing of all of the things we learned and did that day. All tends to happen in deep sleep and REM sleep. And so if you're getting less of that, there's going to be sequelae. They tend to spend more time in what's called lighter sleep. And the consequence of that is it's easier to wake up, sometimes for no reason at all that they can be aware of, but because they're kind of sleeping like the princess and the pea. So a little bit, doesn't take much. And then sleep efficiency decline, which means that older adults are expected still to get around 7 hours of sleep. Again, there's a spectrum of normal, but average about 7. However, the efficiency of getting those 7 hours is a problem. So it tends to take older adults longer to fall asleep, and then they wake up more often. Okay, all of this is normal. And I realized just off the bat as I was saying it, it might sound pathologic. And I bet you have talked to patients who were complaining about some of these things. At least a portion of that is going to be just their physiology and just how their brain works. I really like this graph that was taken from one of the articles referenced at the bottom that shows kind of the distribution of that less deep sleep. Older adults are in the blue, younger in the purple. Less deep sleep, more light sleep. And there are actually some numbers here too from Serial PSG that it's not a small change. We're talking about 10% roughly swings from one type of sleep to the other. And if you think about a 7 hour night sleep, like that's not that's not inconsiderable. Like all things age related, it doesn't happen overnight. It happens very slowly. And the changes, those three big buckets of changes that we talked about, really start at age 50. I'm not going to take a poll in the room, but I will tell you that I am 41. And so when I reading all of this and learning all of this, I was thinking, holy crap, that it is too early for me to start thinking about this. But really, changes can start happening around 50. And this has been in the media more often lately, particularly amongst physiologic females because of perimenopause. And so some women, physiologic women, even start having sleep issues earlier than 50 that are now being kind of attributed to the perimenopause syndrome. And it's really a gradual change that really doesn't stop or kind of plateau, I guess is the better word, until after age 70. So this is something that is happening right around the same time as menopause and andropause, and happening over the course of a couple of decades. And so you can see it's the circadian rhythm shifting that starts first, then the shifting in slow wave or deep sleep over to light sleep. Um, this is where age 60 to 70 also where we start to recognize clinically and diagnose some of the sleep disorders like obstructive sleep apnea. Lots of people are diagnosed at this stage of life as well. So there's it's not just physiology, it's also pathology that comes into play here. And then by 70, most older adults have that advanced sleep phase syndrome, excuse me, and want to go to bed around 7 or 8 p.m. And then they're up at like 4 or 5 in the morning. I could tell you some stories from working in post-acute and long-term care. And I know those of you in the hospital probably have seen the same thing, that standard medication dosing regimens, right? QPM and QHS are 2100 and 2200. And so it actually does not match the physiologic average of what our older patients are going to want to do at that stage. Same for QAM. I know in my facility, QAM is 9 a.m. And at OHSU in the hospital, it was 9 a.m. And I had patients that were up at 5 a.m. begging to get their morning medications. And so that's why we're seeing these things. It's not just like, oh, well, you're just an early bird. It's because their brain actually works that way. All right, pathology. The common sleep disorders, again, we're really going to focus in on primary insomnia, obstructive sleep apnea, restless legs, and periodic limb movement disorder. There's a lot of numbers and a lot of text, meant to be more of a reference for folks who like pulling up slides or having kind of one-page slides to be able to go back to later on. The really prime takeaway here is that sleep disorders, not just physiologic sleep changes, are incredibly common. I know there are probably a lot of PCPs on the call here on Teams. I imagine all of you are thinking, oh, yes, yes, yes. Talking about this a lot with sort of midlife and older patients. Diagnoses have some shifting different prevalences. There are some gender differences, particularly when it comes to obstructive sleep apnea, much more heavily and commonly diagnosed amongst males than females. Part of that's probably a recognition issue, and it's sort of how OSA was originally recognized and taught to us. But even look, there's almost 40% of people that just describe like, I am not getting the restful sleep that I need. Right. And so pathology there, but what pathology we don't know. So there is kind of a big Venn diagram of people that would fall into these categories. We're going to talk a little bit later on about caregivers, spouses, even children that are caring for ill or aging partners or adults that, and the sleep changes that come along with being a caregiver and that as a risk factor. Cognitive impact actually has a bidirectional relationship with sleep. So there are sleep symptoms of all sorts of cognitive and psychiatric disorders, bipolar, depression, dementias, all of them. But then sleep disorders and sleep impairment is actually a risk factor for developing all of those mental health and cognitive conditions. So it's a two-way highway there. There's actually been a great meta-analysis, I believe meta-analysis in JAMA Network Open within the last couple of years that calculated an odds ratio of 1.4 times increased risk of developing later dementia in life from people who are not sleeping well in midlife. So this is also a lifelong condition. When you're seeing a 40 or 50-year-old that's having trouble sleeping, you may not be thinking about it right away, but looming on the horizon for that person might be a dementia diagnosis down the road. And then medical comorbidities. You'll see this a handful of times. I realize I'm sitting in a conference room of internists and pharmacists and lovely, lovely people that know all of this, but there is a substantial overlap between pathologic sleep and things like heart failure, especially things like central sleep apnea with advanced heart failure. Diabetes can screw with your sleep cycle, along with a whole host of other conditions that we'll mention. Older adults, as a demographic, are going to have a higher prevalence of primary sleep disorders compared to their younger counterparts. Doesn't mean younger people have zero issues sleeping. It's just a higher prevalence over the course of the lifespan. And so here's a little bit deeper windows into those diagnoses, and we'll go a little bit deeper in the subsequent slides. We've talked really about the insomnia pattern of difficulty initiating sleep. That's a key feature. Sleep maintenance issues. So what we're talking about there is lots of awakening, and then I can't get back to sleep is often what people will say. And then early morning awakenings before the desired wake up time. Put a pin in that, we'll come back to it. Sleep apnea, again, the obstructive sleep apnea prevalence is about 70% in males and about 56 in females. There are some anatomic changes that we'll talk about later on, but otherwise there is really no great reason, physiologic reason, there should be a gender difference here. And I wonder if this is primarily because the way I was taught was thinking about things like neck circumference. And it's actually much more common for women to not have a sort of sleep apnea with a very wide neck circumference. And so I wonder if maybe there was some gender bias or sort of body type bias in this. Um, Excessive daytime sleepiness is often the most common presentation of untreated, undiagnosed OSA in older adults. That they will, you'll hear about excessive napping, or you'll hear family members saying this person gets up, they have breakfast, they go right back to bed. They sleep for a couple hours, they get up, they have lunch, they're right back to bed. That is excessive daytime sleepiness, and that is not normal for an older person. So that should raise your feathers thinking about OSA. But the other that I know seems very strange. Oh, I don't have a pointer. Anyway, very strange to think about is nocturia. Nocturia actually has really good evidence behind it to be a primary symptom of OSA. And I didn't know this for a very, very long time. I know my default was to wonder about things like overactive bladder, drinking fluids or caffeine too late in the day, BPH in males. But really, it is actually a very good sign of undiagnosed obstructive sleep apnea. And there's a couple of reasons for that. First, the apneic periods actually trigger sort of stress hormones that actually increase urine output and the urge to urinate. And then those apneic periods, one of the effects of the hypoxia or the physiologic stress of the apnea is the bladder contracts. So I'm on record as having said the bladder is the body's stupidest organ, and this is just another way in which it does that. Um, Movement disorders, very, very common. RLS, especially in earlier life, and that's generally not something that goes away with aging. So these kind of midlife folks that are dealing with restless legs, we can expect they will be dealing with that for decades to come. And then parasomnias, which is technically where REM sleep behavior disorder fits in. What the big point that we're going to talk about in this talk, and that's really it, is that there is a strong overlap here between REM sleep behavior disorder and the neurodegenerative conditions. So if you are talking to someone who's got a bed partner saying, oh my gosh, they're acting out their dreams, I'm getting punched in the middle of the night, kicked, not just a little kick, but like really kicked in the middle of the night. We are having like physical altercations. You should be thinking about this diagnosis. You should also be thinking about, is there a dementia going on? And is there particularly Parkinson's going on? Because that has the strongest overlap. All right. We've touched on a lot of this already, but 3 big buckets of clinical presentation of chronic insomnias or primary insomnias: difficulty falling asleep, difficulty staying asleep, waking up about 2 hours or more before the time they would want to wake up. Those are kind of the big 3. Patients often will come in complaining of those on their own, so you don't have to do a whole lot of digging. But if you're talking to someone who you're trying to figure out, is there a primary sleep disorder here? What is going on? Those are good 3 questions to start with. What difficulty, or how do you fall asleep? Easy, difficult, hard, not as easy as it was before. How difficult is it for you to stay asleep? How many times are you waking up during the middle of the night? Next good question is to ask, why are you waking up in the middle of the night? People with true chronic primary insomnia will say there is absolutely no reason. I am just awake. But asking that question is really important because there are like a billion other reasons that people wake up during the night. Sometimes it's the dog, the cat, my bed partner, the pillow I have is 50 years old and doesn't have any fluff anymore. So I wake up because my neck hurts or I have a headache. It's too hot, it's too cold, right? You can actually get to a lot of the sleep hygiene environmental stuff pretty quickly in asking that question, even if you're thinking primary insomnia. Uh, and then the early morning awakenings, getting a sense of when do you want to wake up? When are you waking up? And what we want to see in order to justify a diagnosis here is this happening on average 3 nights a week for 3 months or more. Because situational insomnia, right, periodic kind of temporary insomnia is also a very real thing. Maybe from medical conditions, maybe from chaotic living situations, big stressful changes. And so that 3 month period really is pretty important. If it's only been a couple weeks, you may want to think about what in your life might be sort of driving this. OSA. OSA is probably amongst my patients the most common primary sleep disorder that I see, and I bet there's a fair amount of folks in the audience and on teams that would say like, yeah, that's probably about right. The graph here, the chart, actually shows the breakdown that 70% of males compared to 30 have OSA compared to 30 without, and then 56% of females compared to 44% without. So there's that sort of visualization of that gender bias again. Let's go back to the pin. We had talked about some upper airway changes, just physiologic, that are expected with age, that I think do kind of play into this gender bias. Um, all of us, as we age, will experience a lengthening of our soft palate and then actually have more fat pad deposition sort of in and around our upper airway and our pharynx. This is nothing you can do anything about. This is just all part of aging. But what it means is that you've got more material in kind of a small area that where air needs to go through when your body is completely relaxed. And so this leads to, I think, the archetype or the phenotype of the very skinny, very thin person with bad obstructive sleep apnea. Yeah. Okay. Oh wow, I put the room to sleep. Okay. Um, and that is particularly true in females. I've seen a lot of women over the years that didn't have an elevated BMI, didn't have other sort of classic risk factors that may be falling into this camp, that we weren't seeing it on the outside. It's what's happening on the inside that's actually driving their risk and causing their problems. Remember too, presentation can actually be different amongst older adults. The classic snoring and witnessed apneas is actually a little more common in males than in females. All right, the movement disorders, restless legs and periodic limb movement disorder. Um, RLS incidence and prevalence peaks around age 65, but those people with true primary RLS are probably going to live with it for the remainder of their lives, the bulk of it. For those who haven't experienced it, it is awful. I had a terrifically bad iron deficiency last year and developed symptomatic restless legs, and it was horrible. I didn't sleep for a week because it's not actual movement. It is this intense restlessness. Like I need to move my legs in order to get more comfortable. And then you do, it is comfortable for a few seconds or two, and then it all comes back. And you're in this cycle all night long. So when people with RLS are really complaining that it's miserable, it is truly miserable. And there is a almost circadian rhythm to it where symptoms tend to get worse over the course of the day and particularly bad at nighttime. There are some people out there, the unlucky few, that will even experience some restless legs symptoms during the daytime too. And you may see these folks treated with like TAD Sinemet or multiple times a day pramipexole or ropinirole for that because it is really uncomfortable. Periodic limb movement disorder exists kind of on the same spectrum, but is actual observed movements during phases of sleep where there shouldn't be. So this really is a polysomnography diagnosis. Very much like the apnea hypopnea index, they're looking for more than 15 movements per hour alongside symptomatic sleep disruption. So you may not hear about this from patients, you may hear about it from their bed partner, but this is usually a diagnosis you're going to see from the sleep lab. And you can think about the movement disorders as existing on a spectrum. So restless legs, periodic limb movement disorder, even REM sleep behavior disorder kind of all exist in this Venn diagram, loosely organized spectrum. And so you may have patients that don't really fit into one diagnosis or that have features of multiple. And that is not unexpected because of the poor definition, poor understanding of these conditions, and more to learn. All right, diagnostic considerations. We start with older adults, the exact same place we would start with anybody. You want to get a complete sleep history, okay? If you have the opportunity to hear not just from the patient, but also the person they sleep with, that is a win. So if it's a couple or I don't know, any combination of people that sleep in the same bed together, it would be really ideal to get them both together in the office or on the visit to ask, what is your experience, but what is your bed partner's experience too? Because they may often observe or have observed some symptoms that the patient isn't even aware of. You also want to ask about previous treatments. How long have you been dealing with this? The context. So life context, health context, environmental context. Did they move to a new place? Again, the pillow or the bed 50 years old, which believe it or not, I see a lot. Mattresses are only supposed to last 8 to 10 years, by the way. They're not meant to last an entire lifetime. So sometimes the treatment is as easy as here's the website for Sleep Number or Tempur-Pedic. And then I do, when I have the opportunity or I'm really thinking, gosh, this could be a primary sleep disorder, really do like to use a structured index like the Insomnia Severity Index or the Pittsburgh Quality Index, because much like the PHQ and the GAD, you can use these to track over time disruption of symptoms. So it really is a nice objective parallel to people's self-report. Sleep diaries can still be done by older adults. Even those with cognitive impairment, sometimes their bed partner can actually do that with their observations. It's not perfect, but it at least is something. You're going to get things like bedtimes, waking times, how often they were awake during the night, what they did during the night, those sorts of things. And so it can still be really useful. And then older adults are still good candidates for sleep labs. So polysomnography, actigraphy, patients with cognitive impairment, this can be a real struggle. And so I would really think twice about those folks. Early cognitive impairment, mild cognitive impairment, those folks can do okay in the sleep lab, but it can be a really difficult experience because they wire you up. There's the end-tidal CO2 mask. You've got all of these things attached to you. It is already a really crappy night's sleep. So my dad says, and someone with cognitive impairment is really going to struggle in that kind of environment. So it's still a tool in the toolbox. It just may not be the right tool for everybody. What's really important for most of our older patients is that not all sleep syndromes or sleep complaints are primary sleep disorders. Granted, primary sleep disorders are super common amongst older and aging people, but they are one bucket. There are lots of other buckets that we need to upend and investigate in order to determine, am I really dealing with a primary sleep disorder? And so these are 3 of the big buckets that I think about, that the evidence suggests that we think about. Chronic medical conditions, heart failure, diabetes. Think about physical pain from things like polyarticular arthritis, autoimmune conditions, people living with chronic pain that for whatever reason or various reasons might flare at night. Reflux, multiple neurologic disorders that it's a primary symptom of their neurologic disorder. Parkinson's, the dementias, MS can all have associated sleep symptoms. Even urologic disorders can definitely have sleep-related symptoms. So it makes our job more challenging when we're seeing a 75 or an 80-year-old that has a problem list that's this long, and their chief complaint is, I'm not getting restful sleep. because really the first things we need to do beyond taking a history is thinking about how is your control? How are we doing controlling things like orthopnea? How are we doing controlling things like chronic pain at nighttime? And that's just one big thing that we need to do. Psychiatric and cognitive factors, we talked about that bidirectional relationship between sleep issues and mental health conditions and cognitive conditions. So always keeping those kind of on the to-do list. Are we seeing an early sign maybe of an evolving or blossoming depression or anxiety disorder? And then medication side effects, which I'm going to talk about right now, because I bet some of you are looking at this and thinking, beta blockers, what the heck? Remember that multiple drivers can exist here simultaneously. So you can have someone who may end up having obstructive sleep apnea who also has sleep issues related to their BPH, and they're on a couple of risky medications. So don't just stop when you pick up one thing. It's a classic geriatric syndrome. You got to look for everything. So beta blockers. Beta blockers actually suppress melatonin production. I know. I know. I was thinking just in the past couple of weeks, I think 90% of the patients I saw in my buildings were on a beta blocker. It is greater suppression from the non-selective beta blockers. So there's that. The propranolol, the atenolols tend to do a little more of this, but it's definitely seen even with the beta selective beta blockers. They can, for some, cause nightmares. They can actually lead to some sleep fragmentation and then early morning awakenings. I know. The good news here is that melatonin is supplementable or replaceable. So for those people who just cannot right now be off of their beta blocker, we do have kind of a workaround. It's not the best, but this is not not going to upend the way we treat heart disease, heart failure, and a whole host of other things. Diuretics, you always want to think about timing. So asking someone, when are you taking your Lasix? When are you taking your spironolactone, your HCTZ or chlorthalidone? I have been very surprised over the years. I just assume people want to take it in the morning and get it over with. Sometimes people are like, nah, I take it with my lunch. Or I forget it a lot and I take it at nighttime. I'm like, okay, well, that's an easy fix. And then corticosteroids too are just primarily going to interrupt and disrupt sleep. We definitely always want to dose them in the morning, but in older adults that can still screw with their circadian clock and mess with their sleep. So another reason to try and get older people off of corticosteroids or down on the dose to below a physiologic dose as quickly as possible. Cardiovascular, metabolic conditions, heart failure and central sleep apnea is not something to lose track of. This is particularly common in the advancing stages of systolic heart failure. I don't know, and I didn't come across any new understanding of really why that is, but it is a very strong correlation between the two. So if you're treating someone who you know has an ejection fraction in the 20s or 30s, who's had heart failure for a while, you're getting maybe a suspicious sleep apnea history, I would keep this on your differential. Diabetes, of course, and then CKD, one thing we don't often think about, in people with advanced CKD, the evil humors, are we too old for that? Am I too old for that? There's too many young people in here. When your kidneys are not working all that well, especially when you're on dialysis, there's only so much that a sick kidney or a renal replacement therapy is going to be able to filter and clean out of your blood. And so I use the term evil humors because a sick kidney or a dialysis patient is always going to have some toxic byproducts of metabolism left behind that their kidneys just aren't able to scrape out. And this might be the reason that we actually see an increased risk for restless legs in people with CKD. I don't know this for sure. This is just Dr. Drago's theory, but it does kind of track for me. And then GI and GU disorders, reflux, nocturnal heartburn, incredibly common, always worth asking about or considering. Asking too about diet and mealtime habits. When are you eating compared to when are you going to sleep, right? That's an easy thing. If we can eat a little earlier, lie down physically a little bit later, you get a little more distance between your dinner and your esophagus. And then BPH, which can, remember, nocturia can be a sign of primary obstructive sleep apnea. It can also be a sign of undertreated BPH. So this is part of why we need to kind of look at everything. It's going to be a lot easier to increase, if you can, your medical treatment for BPH, see if that helps the nocturia. If it doesn't, then I would really be thinking we need to get you into a sleep lab. Address what you can first before labeling someone as having a primary sleep disorder. Makes sense. Remember, don't leave anything out. Kind of think about everything. Use a review of systems if you need to, just to make sure you're hitting sort of the different big buckets. And really, if I can leave you with one thing, it's to pay attention to sleep issues in older adults. We're all guilty, myself included, of having dismissed the older person who was saying, I'm not sleeping all that well. I'm feeling more fatigued during the day. Because that complaint could literally be one of a million things, right? But sleep disorder, sleep issues in older adults can often be the canary in the coal mine that something else is going wrong. Either a primary sleep disorder that is just now kind of bubbling to the surface, or some major change or intolerance or evolution of their medical conditions. And so it's worth taking a pause and kind of paying more attention to, even if you're tracking over time and you do something like a sleep diary. There's some good apps now for sleep diaries. Even if you're doing that, at least you're getting some more data and you're paying some attention to it. And then again, work through your differential diagnosis before attributing this to it's just normal aging, right? Normal people want to fall asleep at 7, 8 o'clock at night and wake up at 4 a.m., right? That's just normal. It's not normal until we've ruled out those reasonably abnormal things. Okay, the treatment toolbox. I'm paying attention to the clock too. Evidence-based treatment for chronic insomnia, first, second, and third is CBTI. And we'll talk about why. CBTI actually has better efficacy than all of the medications that we use for sleep. It is very much like uses a lot of the principles of cognitive behavioral therapy, just really focused on sleep. And it is incredibly effective. We'll talk, there's a slide in here with the components of CBTI for those who aren't familiar. Sleep hygiene is also important. Relaxation techniques like mindfulness and progressive muscle relaxation also can be really effective in older adults. All of that and more is going to be the first line before we consider medications, because the medications are a fraught minefield for our patients, right? No benzos, no more temazepam, no more Ativan, no. It will cause your patient to fall. It will eventually land them in the ER with a fracture, or in your office or in the hospital with a dementia diagnosis. We really do like the melatonin receptor agonists. I particularly like melatonin, not so much Ramelteon, but Ramelteon is still on the market. And you can see why, that there are medications that can interfere with melatonin production, and there's a natural decrease in melatonin production over the lifespan. And then doxepin, we'll talk about in a couple of slides. It has FDA approval for primary insomnia, even though it is an old school antidepressant with some TCA-like qualities to it. All right, CBTI really focuses on these three big buckets. So sleep assessment and education. So the therapist actually does a deeper sort of comprehensive sleep history, more education, and kind of a deeper dive than maybe we could do in the office on what your environment is, what may be sort of the other factors. Then they really get into things like stimulus control and sleep restriction. So for people who are napping during the day, finding ways to avoid or distract or move away from that napping during the day in order to consolidate sleep at night. And they can be really effective at this. And then dismantling some of those cognitive biases that are really common in primary insomnia, the people that when they get into bed, they have so much anxiety and kind of augmentation, right? The spinning out phenomenon when they're in bed, saying to themselves, I'm never going to fall asleep. This is never going to work. Oh my gosh, this is never going to work. Why do I even try? Right? That's the anxious sort of insomniac spinning out. That's the CBT part of CBTI, is dismantling some of those negatively reinforcing thought patterns. Sleep hygiene, still really important with some caveats here. So it's all the usual stuff. The caveats I want to bring up is temperature. So the vast majority of us over the course of the lifespan tend to like our sleeping space somewhere between 65 and 68 degrees Fahrenheit. 66 has actually been posited as like the magic temperature. But somewhere in there is where most of us tend to like to be. Again, there's a spectrum of normal. Some like it super cold, some like it super hot. Most of us are in this range. Older adults, because of aging of the hypothalamus, have a harder time regulating their temperature just all the time. That's normal. And so at nighttime, that 65 to 68 Fahrenheit range might actually be too cold for an older adult. And so you may, with a family member, with patients, you may want to advise them to play around a little bit. Let them know your body might want to try sleeping a little more warm in the room. So if you have a heater, if you can pile on blankets, if you can do some things, particularly this time of year, to make the space and your body a bit warmer, that may actually help you sleep a little bit more restfully. Light is still really important to reinforce the sleep cycle. So getting up, particularly this time in the year, reminding people when you wake up in the morning, turn on the lights. Brighter is better. Okay, so turn on the bathroom lights, turn on the lights in your room, right? Walk around the house, turn on the lights. And when you can, get some sunlight, natural daylight, because that reinforces the body's melatonin secretion and the circadian rhythm. Still really important. All right, treatment of the movement disorders. We'll talk about medications in a moment, so just put that aside. There are some good lifestyle things people can do for RLS. So stretching and moderate exercise can be really important. Avoiding sort of the neuroirritants of caffeine and alcohol, and iron deficiency. I've lived this nightmare. It's awful. Keep a very, very low threshold to get a ferritin on anyone you think might be having RLS symptoms. It is incredibly common. I am doing an unofficial little study in my long-term care patients that have restless legs. I have ordered ferritins on all of them, and so far all of them have come back in the like low teens. I know. So probably not going to get published, but it's definitely very scientific. The pharmacotherapy, we will definitely come back to, but I do want to put this bug in your brain that the dopamine agents, the Sinemets, pramipexole, ropinirole, which I know I was trained to use those for restless legs. They are a minefield. They have lots of side effects. They are not always well tolerated. And it turns out they actually increase what's called the augmentation risk, which is just another fancy way of saying it's like the opioids actually increasing pain sensitivity over time. So the longer you've got an RLS patient taking Sinemet or ropinirole at higher and higher doses, you may actually be fanning the flames of the RLS over time, which then sends them to your office asking for more ropinirole. And so getting away from the dopaminergic agents is probably a good idea. They're still helpful for some patients, but probably not first line. And then falls. Anyone who is up motoring around in their room in the dark with no shoes on at night is going to be a hazard for falling. So every older person should be screened for falls once a year anyway. If you're dealing with someone with a sleep disorder, just make sure that either we have done this or we will do this. And then the pharmacotherapy guidelines. So these are the medications that I tend to consider being in my toolbox for different conditions. Full disclosure, I don't use a whole lot of Doxepin. It still scares me. It is TCA based. And as a geriatrician, that's just like rule number one, rule zero that we don't break. But it is FDA approved, and there actually is some good quality evidence that it is safe even for older adults. So you will see patients out there, and there may be patients that you want to try a low dose Doxepin, like 3 or 6 milligrams, to get started with some careful attention to how they feel, and advise them on sort of the anticholinergic side effects, the dopiness that they might experience, and to be very, very thoughtful to let you know. I love melatonin. I will start melatonin on just about everybody. If they look at me wrong, I will start them on melatonin. What's key here is that it's not a dose response relationship. So if someone's having a lot of trouble sleeping, going up on the melatonin is not going to do anything more. I tend to stick to 0.5 milligrams or 1 milligram, and I don't tend to go up more than that. More is not necessarily better. And so once you get into the double digit doses of melatonin, it can actually start screwing with their circadian rhythm even more and make it physiologically impossible to go to sleep for hours and hours and hours and then push their sleep clock into the next day. And so if you're seeing patients that are taking 10, 15, or 20 milligrams of melatonin, get them off of it and put them back on 1 milligram and say, we're going to do some other things instead. You may have to pry it out of their hands, but do some other things instead. I mentioned earlier that the effect sizes in the studies of CBT and medications show that CBT is actually more effective than medications. And here's those numbers. With CBT2, you actually get longer lasting effects that persist over the course of like 2 years, even with a course of CBTI. So you're going to get more bang for your buck, both in initial effect size and in duration. So it really is worth it. CPAP, still the gold standard for moderate to severe obstructive sleep apnea for older adults. However, it becomes a lot more difficult for older adults that are maybe newer to CPAP to start using CPAP. For those who are interested, I'll tell you about my dad, who is now in like year number 3 of his CPAP journey, and he hates it. For all sorts of reasons. There's also some increasing challenges over the course of the lifespan that people with cognitive impairment that maybe can't remember why they have this giant thing on their face during the night, it can actually be more terrifying than it is helpful. Dexterity limitations from things like osteoarthritis and even just stiffness in the hands, so needing some physical help to manage the machinery, the tubing, the mask, and then other comorbid conditions that can just make it so impossible to tolerate that continuous pressure. And so a lot of older adults actually will self-discontinue their CPAP. And so overall, there's an average compliance rate amongst older adults of about 65% because it does become kind of increasingly difficult and miserable. There is a growing body of literature that is looking at the effect of CPAP in the older old, so like over 80. And what we know so far, these are not really long-term studies, is that there actually has been no documented improvement in OSA symptoms, blood pressure control, which is the one sort of quick turnaround physiologic outcome that they can get, quality of life, anxiety, and depression. And so there may actually be kind of a waning effect of CPAP for OSA in later life. Now we don't know, does it still have, is stroke protective? Is it still mortality beneficial? That we don't know, because this is just a recent evolution in the data. Here's a nice clinical decision framework. Just make sure when you're treating that you're thinking about all of these different things. What it by the evidence is most likely to be successful. What are the challenges that this individual person is facing? How does that change my options to help treat them? What are the safety concerns? And then even thinking about some cool things. Older adults do use Apple Watches and Fitbits and fit trackers and things like that too, that a lot of them actually have sleep tracking functions on them. The Oura rings too, those have sleep tracking functions on them too. So now asking, are you using some sort of tech device? I have a Sleep Number bed and it tracks my sleep, which is like the best commercial ever for Sleep Number, but it really is wonderful. And on the app, I can actually check like how many times was I awake last night, even if I didn't feel like it. Caregivers and health. Oh, wow, that didn't go the way I wanted it to. Being a caregiver, really bad for your sleep. Really, really bad. This is probably all mished up too with the fact that caregivers are at higher risk of heart attacks, depression, lots of other medical issues that may converge kind of at multiple points, including sleep. And then dementias always come, usually in the moderate and later stages, with a sleep disorder. Disruption, sometimes even complete sleep-wake reversal, where they are awake all night long, that is their daytime, and then they're sleeping all day long. This is a normal part of the spectrum of dementia symptoms, and you are never going to break a person with dementia of it. So the best way to treat someone with that kind of partial or full sleep-wake reversal is to make their daytime feel like their daytime, which can be really challenging if you've got a person with dementia and their caregiver spouse living at home. And that caregiver spouse maybe works, needs to have a social life, needs to conduct the business of the house. So it gets very, very complicated, but just know you are never going to break that person with dementia of this. It is what their brain wants to do. Treatment outcomes. So this is looking at success rates sort of by bucket. And for those who are visual learners, that giant column on the far left-hand side is CBTI. And you can see the short term in the purple, the longer term meaning 12 months in the blue, and then the sustained meaning 24 months in the teal up top. So across the board, it's going to be better and more long lasting. The second column is medication. The third column is combining things like medication and lifestyle interventions, and then which still doesn't beat CBTI, and then lifestyle only, which is really falling out of favor. We should not be solely focusing on lifestyle and environment. That's important, but it should be that plus something else. All right, we're going to shift through this. Red flags and referrals. So if you're treating patients who show up with one of these sort of syndromes, this is really when you should be thinking, oh boy, urgent referral to sleep medicine, neurology referral for Parkinsonism and REM sleep behavior disorder, narcolepsy, something we don't see all that often, but if you even think this could be narcolepsy, call sleep medicine. And then for anyone who's having sleep attacks or falling asleep at the wheel, it does not matter why that's happening. You need to advise that person that they need to stop driving immediately. Because if that happens on their way out of your office or away from the hospital, that would be horrifying for all of us. And so this is where you would send a DMV report. We are all mandatory reporters to the Oregon DMV. So this is that case where you would be duty bound to submit that report. Poor sleep, not an inevitable consequence of aging. Okay, so before we are talking to people and saying, yep, that all sounds normal, we do want to do our due diligence and make sure that it is not something abnormal. We're going to take a very brief detour through the hospital because all of those patient level factors that we just talked about, people bring those into your care, and then we layer upon them the joys of being in the hospital, like the 24 hours, 24/7 always open phenomenon where the lights are always on and there's beeping and dinging and people talking all night long. It's like a casino and you can't tell what time of day it is. And then the environment, right? We've got noise, we've got light, we've got people coming in, people coming out. My roommate is having a STEMI, so the entire hospital is in my room, right? Like that is just the reality. And there are lots of consequences here that including post-discharge outcomes. Okay. Not just for when they come to me in post-acute rehab, but even longer term with things like readmissions, ER visits, poor sleep in the hospital is a bad thing. I did end up using, and I think most of us do end up using medication for short term in the hospital, and that is perfectly reasonable. This is my kind of simple algorithm that I used to use when I was doing hospital-based care. Again, melatonin for everyone, okay? Everyone. Doesn't matter who you are, everybody. And then if I needed to layer on top of that something else, I would tend to go to a little bit of trazodone or a little bit of quetiapine or olanzapine, especially if I had someone with delirium who was having some behaviors or psychosis. So the antipsychotic was sort of serving two masters. General prescribing pearls, start low, go slow. Picking a dose is generally better than a range. Nurses sometimes don't know what to do with ranges. Prioritize scheduled instead of PRN, because what will happen is that person will wake up at 4 a.m., maybe normal, and then some kind, very warm-hearted nurse will say, oh dear, you're awake? You have some PRN trazodone. Can I give you some PRN trazodone? And they get it at 5 a.m. and then they sleep all day. So tend to shy away from the PRN and more towards the scheduled. And then don't forget that you have a lot of non-pharmacologic tools in your toolbox to make the environment a little more peaceful. Whether it's retiming medications, getting rid of overnight vital signs, giving nurses permission to stay out of the room for a stable patient, you can do all of that as the hospital providers. So don't disregard some of these things, because even an eye mask or some earplugs can actually be really effective. All right. Thank you all. I see 8:54, so hopefully we'll have a few minutes for questions, and I'm happy to stay after 9 a.m. for folks who want to stay and ask questions.
Great. I am certain we have questions in the room, no doubt. Okay.
Thank you for a very comprehensive talk covering a lot of ground. I was curious about the lack of response to CPAP in older adults. Do you have any thoughts on the mechanism of why it's less effective as we get older?
That is such a good question. Leave it to Dr. Laura Perry to ask like a difficult question that I don't have the answer to. We don't know. We don't know. I think there are some good hypotheses for why that is. There's also a higher burden of like amyloid plaque in the brain after age 80, vascular damage in the brain, even if people haven't had strokes before, right? It's just a more friable system, I guess, is maybe the better way to put it. You've got cerebral atrophy as well. That's just a physiologic part of aging. So it may be part of this sort of complicated neural networks that we're learning about, the way different brain functions kind of shift in different parts of our brain over the course of our lifespan in response to areas of damage like a prior stroke or something or previous head trauma. We don't know. So TBD on that.
Yeah, thank you so much for your talk. A lot of insurance companies now are steering patients towards doing home sleep studies first, rather than polysomnography off the bat. And sort of, where do you see like what's the clinical role of home studies versus a PSG?
Great question. So older adults should not be summarily excluded from home sleep studies. There are a lot of older adults that can manage the machinery and stuff and may have a family member or someone who can come and help them get trussed up. Here's my worry, that we know that home sleep studies are not as accurate as polysomnography in the sleep lab. And so what ends up tending to happen is that the home sleep study is a really good, not a screen really, but a first step to rule out sleep apnea and only sleep apnea. But if you get anything other than a truly negative home sleep study report, you're going to end up sending that person to the sleep lab anyway. Or if you have any concern for a movement disorder, a parasomnia, something more complicated, a home sleep study isn't even going to capture that. So it's really only useful for, I don't think, you really might have obstructive sleep apnea, but let's do this first just to make sure. That's kind of the role for it. Anything else, really, for an older person, I would probably fight with insurance to say, I don't think that a home sleep study is not going to get me the clinical information that I need, and you as the payer are just going to end up wasting your money.
Great. A couple just real quick details to clarify. Can you talk about the timing of the low dose melatonin, and then also any practical tips for helping patients access CBTI?
Oh boy. Okay. So timing of melatonin. You want to take the dose of melatonin about an hour before your expected or intended bedtime. And in that hour, that is the perfect time to turn off the TV, turn off the screens, read, do whatever sort of calming thing, curl up with the cat or the dog, listen to the rain. That's your time to, and your signal, right? Melatonin kind of starts that hour of progressive relaxation. So that way, in an hour, when you get into bed to try to go to sleep, you've already kind of set yourself up for success. So I know people that really like using things like chamomile or herbal tea, lavender, which is wonderful for some people. That's your time to bring those things kind of into your environment. Again, most older adults, their intended bedtime is kind of around 7 or 8 p.m., but there are older adults, their bedtime is 11 p.m. So that's why the general rule is an hour before your usual or intended bedtime. And then CBTI. It is the gold standard. It can also be very tough to access right now. So there are some in-person therapists that are doing it. And so I would look into and maybe press Providence, the health plan, their partners, who is doing CBTI like in our network. And again, this may be a hill to die on too, that like this is the most beneficial, the most cost effective, right? This is what we need. You need to give it to us. This might be a good hill to die on. I have heard recently, some apps that are helpful with CBTI. I haven't heard much like raving reviews about them yet though. So I'm still a little skeptical about the apps, and AI just scares me. So I wouldn't don't tell people, do not go to ChatGPT for this. We don't know what they're going to say or do. So I would try really hard to get that person into an actual therapist. It can even be virtual teletherapy too. So yeah, it's not a great landscape right now.
Well, perfect. I noticed we are just at 9 o'clock. Thank you for covering a wealth of topics all on sleep.
Thank you all so much.